Hello, all of you. Welcome to the today's session on surgical update. And this surgical update is specifically meant for short videos for you to go through these important topics for exam, and then you can remember and you can also revise. Okay, we'll go into the question. What condition is seen in the picture? What is the characteristic appearance of this? And what is the name of the surgery used to correct it? See, because in the recent exams, a lot of clinical scenario based question, image based with clinical scenario are being asked. So this question is basically framed in those aspects. So what you can see the thinning of the esophagus, and you can classically see it looks like a bird's beak. Yes, it looks like a bird's beak, and then you see that dilated esophagus. So approximately dilated esophagus. So this bird's beak esophagus, okay, is classically seen where? It is classically seen in achalasia cardia, motility disorder of esophagus. See that achalasia cardia, bird's beak appearance, and Hellas myotomy. So this goes in favor what the picture has shown you very clearly. Now, let us look into what is achalasia cardia. Okay. So achalasia cardia, what is the most common cause? Achalasia cardia, the most common cause is idiopathic. Okay. What is the basic pathology in achalasia cardia? In order to understand the basic pathology, you need to understand about the LES zone. So this is an enlarged version of LES zone. Now, when you look into the enlarged version of LES zone, this is the esophagus, this is the stomach, and the dilated portion of the esophagus, this area is called ampulla. Okay, ampulla, and then infundibulum. So number 1 will be ampulla, number 2 will be infundibulum, number 3 will be inferior esophageal constriction, and the 4th will be cardia, this region, and this area, number 5, okay, this area, number 5 is vestibule. So the LES is made up of what? So the LES is made up of supra-diaphragmatic portion. This is called supra-diaphragmatic portion of ampulla and infundibulum. Then in the middle, you have the inferior esophageal constriction. These are the areas, is the crust of the diaphragm which is causing this constriction. And then the 4th is the cardia and the 5th is the vestibule. So this is the infradiaphragmatic portion. So supradiaphragmatic portion of the ampulla and infundibulum. Then you have the inferior esophageal constriction. Then you have the infradiaphragmatic portion of the cardia and the vestibule. See, this is a pressure zone. And the normal LES pressure is, understand, it is 13 plus or minus 5 millimeter of mercury. So it is 13 plus or minus 5 millimeter of mercury. It is very clear that any pressure more than 25 mm of mercury, understand, 25 mm of mercury will always suggestive of achalasia cardia. Very clear? Achalasia cardia. Now, what is achalasia cardia? when I say achalasia cardia, number one, tonically contracted lower esophageal sphincter. Number two, also called hypertensive LES. Tonically contracted LES, absent ganglion cells in the body of esophagus, and absent mesenteric plexus. So this results in A peristalsis. Number 5, A peristalsis is absent peristalsis and contracted lower end of esophagus, classically giving you a typical bird's beak appearance. Bird's beak appearance, and with proximal dilated esophagus is called sigmoid esophagus, and the esophageal wall will be multifold thickened. So thickened, and that gives you a classical tram track appearance. Very clear? Now, primary and secondary peristalsis will be absent. Understand this? Primary and secondary peristalsis will be absent. But tertiary peristalsis will be present. As this tertiary peristalsis is present, you will get a contraction called simultaneous contraction. Now, let us all try to understand that clinical features. This is the pathology finished. Clinical features. Now, clinical features of achalasia cardia. They are number 1, halitosis. Number 2 will be dysphagia. Number 3 will be aspiration. Signs of aspiration to lungs. So very important. Halitosis is bad breath, smell of 2 to 3 days old food, dysphagia and aspiration to lungs and lung complications based on that. Now, if they ask you investigation of choice, it is manometry. As we have mentioned already, any pressure more than 25 mm of mercury is 100% suggestive of motility disorder, especially achalasia cardia. Okay, and bariums follow picture. We saw bird's beak appearance and sigmoid esophagus, correct? So these are things to do with achalasia cardia. Now what we do is, we go to the second part of the video, and this here will stop with this video, and tomorrow updation we'll see in the second part about in depth about management of achalasia cardia.